for you. I would like to inform everybody present that this meeting will be recorded and broadcast live in Microsoft Teams, and then will be uploaded and available for repeat viewing on the Council's website. You should be aware that the Council is a data controller under the Data Protection Act. Data collected during a webcast will be retained in accordance with the Council's published policy. I'm afraid that due to current technical limits in the Council chamber, not all members of the board physically present will necessarily be able to be seen on the camera, but you should be able to hear everybody if they use the microphones. The seating in the public gallery will not be filmed. Members of the public are only able to speak if they have submitted a formal question in accordance with Council procedure rules. Please could councillors, officers and partners attending introduce themselves before they speak at the meeting for the benefit of the public. And just to help me manage the meeting, if any members of the board attending online wish to speak, please can you indicate by raising an electronic hand in Teams, but also indicating verbally. Those members in the chamber can also indicate if they wish by raising a physical hand as usual. When not speaking, all online attendees should put their microphones on mute and switch cameras off. If you wish to speak, please switch on your camera and unmute your microphone and pause for about 3 seconds to allow for the slight time delay in connection. Thank you very much. Just before we start, if I can very politely remind speakers that due to the previous meeting, which will be well lasted for 4 hours, we are hoping that I'd like to ask people to stick to the pre-arranged and allocated time, just to keep the meeting as interesting but slightly shorter than last time. So thank you very much. So moving on with the agenda item 1, declarations of interest. We don't have any. Nope. Okay. Agenda item 2, minutes of the last meeting held on the 20th of January. Is everybody happy with the minutes as agreed? Brilliant. Thank you very much. And moving on to agenda item 3, questions. We have a question from a member of the public, Tom Lake. Mr. Lake, if you'd like to ask your question, thank you very much.
Thank you. There's been much talk over new surgery premises for South Reading over a number of years. Church land appears to have been allocated for the purpose, yet no progress has been made. Will there be new premises or a new surgery in South Reading?
Thank you, Mr. Lake. And we have Belinda Seston, who's going to answer that question. Thank you very much.
Thank you, Tom. Belinda Seston, Interim Director of Place-Based Partnership Development here at the ICB. So, good question. So our response is that the Integrated Care Board continues to liaise with GP providers regarding the potential development of a new site in Whitley. We are also working with Reading Borough Council to update our assumptions regarding housing growth and population change, which will inform decision making around what is required in the area.
Thank you, Belinda. Tom, you have a further question?
I have a supplementary. I'll just ask whether this board will continue to take an interest in this matter.
So I suppose, yeah. So I suppose my sorry, we've got some echo. I suppose my response would be that as developments happen as part of our place-based partnership and wider ICP strategy, then they will come to this board in the way that our processes allow.
Thank you, Belinda. Mr. Lake, you have a second question.
Thank you. Under the Berkshire West Clinical Commissioning Group, we had regular meetings in public of the Primary Care Commissioning Committee. Investments in primary care, closing and opening of patient lists, additional services, vaccination campaigns and additional clinical roles in primary care networks were discussed in public, attracting public engagement. There was also a strong and developing quality and performance report on primary care. None of this is now available to the public. It ceased when the Primary Care Commissioning Committees across BOB amalgamated after the meeting of the 14th of April 2021, almost 2 years ago. Will the BOB ICS seek to engage the public with primary care where they experience much difficulty and frustration? How and when will this be restored? will provision be covered to the depth indicated above?
Thank you, Mr. Lake. And Belinda, you're replying to that question?
Yeah, so, sorry, not an echo. The requirement to have a primary care commissioning committee, so the PCCC meeting in public related to the CCG's status as a membership organisation made up of its constituent GP practices. And it was therefore important to manage potential conflicts of interest. But the structure and the status of the recently formed ICB, the Integrated Care Board, is not the same. And so we have taken the opportunity to streamline decision-making processes as a result. So PCCs were not intended as a sole means of involving the public in decisions. Instead, where appropriate, public service user engagement should have occurred prior to matters being brought to the committee meeting. This remains the case, and we continue to ensure that residents' views have been taken into account when considering issues such as those you mention. Working with GP practices to link in with patient participation groups, Healthwatch and other forums as appropriate. Our ICB also holds public board meetings, and in addition, this Health and Wellbeing Board is also an important link to the public, and we thank you for your question.
Thank you, Sarah. Mr. Lake, do you have a supplementary?
Thank you, I do. Given that that in the answer, the importance of patient participation groups has been stressed, can I ask whether this board will take an interest in the activity and of patient participation groups, particularly in South Reading, where there are effectively mostly inactive groups, and will they look to see that they are meeting regularly and patient-led? Thank you.
So, sorry. So I suppose my response would be that we need to be ensuring that we're hearing the voices across our resident population within Reading. Tom, I think you raised an important point, and I'm quite happy to take that back and speak to our communication lead to make sure that the forums that are being held, that we make sure that they're as strong as they can be, and we listen to the voices that of these forums that are in place. So I'm happy to take that back and come back to you, Tom.
Thank you, Sarah, and thank you, Mr. Lake, for your questions. So we're moving on now to agenda item 4, which is petitions, and we don't have any petitions. So moving on with the agenda then, so we have agenda item 5, which is the Health and Wellbeing Strategy Quarterly Implementation Plan Narrative Update. And Amanda Nagy is presenting.
Thank you, Chair. So I'm providing a narrative update. We tend to provide a narrative update on a quarterly basis and a more detailed dashboard update looking at the data. So I just wanted to highlight some of the great work that's taking place that looks to implement the actions and the priorities identified in the strategy. So in relation to priority 1 and 2, the focus of these priority areas are tackling health inequalities and reducing the differences between different groups of people, and making sure that we're managing health outcomes and reducing those overall inequalities. So I wanted to highlight 2 really wonderful things that are going on at the moment. The RIB board leads on these 2 priority areas, and they have invested in technology-enabled care, also known as TEC, and this provides devices to support people to remain safe, to be as independent as possible in their own homes, and a pilot program will be starting soon, in fact this month, and this will be for up to 12 weeks of TEC to be made available to people based on their needs. So that's just one of the great pieces of work that's being invested in. To align with priority 1 and 2 again, the Berkshire West-wide inequality dashboard has been developed. This has been shared with the Reading Integration Board earlier this year, and there's at present, work is underway to map the inequalities and make sure that we highlight in the dashboard these inequalities against the priority groups highlighted in the strategy. And the goal is that we are then able to identify relevant projects through the RIB board, the Reading Integration Board, to support improvement in these areas. So those are just two great pieces of work that are taking place in relation to priority 1 and 2. And then when we look at priority 3, this is led by the One Reading Partnership, the under 5s work stream, and they have representatives from across the system, including maternity, health visiting, pediatric services, and voluntary sector. And essentially, activity is underway against all of the actions for this priority area. And there's some really wonderful partnership working taking place. So a couple of examples that I just wanted to share of some of the work taking place includes some work that's taking place with the national charity. It's called ICANN. And this is a children's communication charity. And the work they're doing together is to develop culture change for young children's speech, language, and communication skills. So that's a great piece of collaborative working taking place. There's also some bi-monthly one-stop shops for pregnancy advice that are being offered. These workshops offer guidance, support, but one of the key things to highlight as well is this support is also offered to refugees and asylum seekers, and is attended by a range of clinicians and professionals. And these are just 2 examples of a range of different things that are happening to tackle priority 3 of the strategy. And then the remaining 2 priority areas are focused on mental health. One is very much a focus on children and young people, and then the final priority is focusing on adults. And some key things to highlight with regards to the work that's happening with children is that the primary mental health team, they're working towards reducing wait lists for children and young people, particularly those with moderate mental health needs. They're offering one-to-one support for that extra, support and attention, and interventions for children and young people in general. And then finally, with regards to an example of some great work taking place addressing children's mental health, the educational psychologists and the primary mental health team are also offering free mental health surgeries to schools, which is really great, as well as training and workshops for parents. And then last but not least, with regards to the mental health focus area for adults, likewise with the other areas, there is progress taking place across all actions, but in particular of note is that work is ongoing around making sure that the workforce are upskilled through a range of mental health training sessions, and these include mental health first aid and a range of other courses delivered by Campus Recovery College, who also offer free workshops within the community. So these are just some of the highlights of the great work that's taking place and working towards addressing the strategy priorities. Happy to take any questions.
Thank you very much, Amanda. Do we have any questions from colleagues? Councillor Brock.
Thank you, Chair. Oh, you asked us to introduce ourselves, didn't you? I'm Jason Brock, leader of the council. Thank you for the update. Really interesting as ever. The one thing and I love a tracker, I really do. It's always a very helpful thing to have, and it's really good to see so much progress against so many things and nothing rated red, and only I think 4 things rated amber. I just wanted to sort of clarify, perhaps for my own benefit, what makes something amber, because from the narrative commentary accompanying, it's not entirely clear. Is it that these things are running slightly later than envisaged? Is it because some elements of the action might no longer be realizable? Just sort of a definition of how things are coded, red, amber, and presumably red would be quite helpful.
Great, thank you. I think in general, the rating is not based with regards to whether or not the action is not going ahead per se. It's more to do with how far along the journey of completing these actions had. So if I give you an example of one of the areas that is amber, there is an indicator around development of a mental needs assessment. This is due to be completed in April, end of April, and the bulk of it has been developed, has been produced, but because of the time that's passed over the last year, what this has meant is some of the data has now become outdated. So we're doing a data refresh, and by end of April, we're hoping that everything will be in place. And this is why it's been rated amber, because the bulk of the work has been done. With regards to green, it's in relation to, again, all the sub actions underneath that action are actually taking place, and the work is ongoing. And if it's red, it's purely the fact that no work has commenced in that area. So unfortunately, it's not the most precise way of rating, but it gives us an idea of the progress to date.
Councillor Buck.
Thank you, Chair. Just a quick result, very helpful. And you can kind of see, I suppose, it might be helpful if some of that were captured in the narrative, particularly when something is amber. Why is it amber? Because that particular method is a little bit distinct to how some things are sort of captured, RAG rated in other areas of the council. So it's not quite, and I can understand why it might be inconsistent. That's fine. But just being able to understand how that conclusion is arrived, that'd be helpful. But thank you very much.
Noted, thank you.
Councillor Hoskin.
Yeah, no, thank you. And your answer to Jason's question helps. I can't help noticing though that all the 4 amber areas are all ones relating to mental health, and I just wonder if there's any reason, is that a coincidence, or is it something around a bit of a delay in terms of the working around that in particular?
So I think that's a great question, and I think they relate to that because in particular the mental health areas are looking at supporting those people with, at risk of poorer outcomes, and those people that tend to experience higher prevalence of mental health conditions. So this includes target groups such as refugees, asylum seekers, homeless individuals, and I guess it's a little bit more challenging to tackle, or to, how can I say, it's a little bit more challenging to implement the work and to find the right pathways to support these groups of people. And there is work underway, but it's less of a sort of a direct approach. So we're in the process of forming partnerships, of actually collaborating with different partners who have connections with organizations that are supporting refugees, asylum seekers, and so forth. So it's more to do with the rate of progress in comparison to the other areas which tend to be easier to progress at a quicker rate, essentially. But I would also say it's not a reflection on the fact that it's mental health specifically, but more the types of groups we're trying to work with.
Thank you. That's really helpful. So sort of more the complexity of the work is.
Exactly.
And sorry, I realised, Chair, I didn't introduce myself like I was supposed to. So I'm Graham Hoskin, Lead Councillor for Children.
We'll forgive you. Thank you. Do we have any further questions? No, thank you very much, Amanda. I was going to actually ask for you to expand on any of the issues, but you did that anyway, so that's covered that bit of the question for me. And just to raise, I went to an event at Sun Street this week, and it's a service that's supporting refugees and antenatal care, and I saw the health checks that are happening. So it's really good, I think, for us as councillors to actually get, to read the priorities in a report, but actually seeing it in action. It was, and I could see the people that are obviously benefiting from the service. So it's really good to see. And what I was going to ask, what can we do as a board to support your ongoing work?
I think just to continue to back it, and to the fact that we're able to attend on a quarterly basis and provide updates and make sure that you're aware of the work that's taking place. That's, I guess, at this stage, I would say that's the most important thing, because sometimes we may commit to a range of actions, but it's very difficult to find a platform where we can share that progress. But I think there's probably more I could say, but it's something that I think we need to think on further, because there's some work that's taking place to map an inequalities report that's been done, and we want to see, we want to be able to identify areas where we can improve upon. So it might just be a case of us coming, in future with some suggestions of further work that can be taken, that can take place going forward. But for now, just having this platform to share the progress, I think is much appreciated. Yeah.
Okay, thank you very much then, Amanda. Thank you.
Thank you.
Okay, so we're moving on now to agenda item 6, which is the integration programme update, and we've got Bev Nicholson here.
Thank you very much. Is that better? Can you hear me now? Too short, that's the problem. Okay, I'm just going to pop that on to, is it sharing? It's not sharing. Let me share that again. Share. There we go. Lovely. I'll pop it on slideshow so everybody can see it. And it will be a whistle-stop tour because I'm assuming that people have had an opportunity to read through the paper. So just an overview really of the Better Care Fund targets that we have, the national targets, and performance against some of the Reading Integration Board projects, and the Adult Social Care Discharge Fund, which was granted through the Better Care Fund. So you can see there we've met 3 of our Better Care Fund national targets for the quarter. The only one that we fell short on was the 91 days showing effective reablement, where people are still at home at a snapshot of 91 days after they were discharged from hospital. And we do have a task and finish group that's working on addressing some of those concerns around, why we're missing the target and are the referrals appropriate. So we're meeting with some end-of-life colleagues as well in the Integrated Care Board and within intermediate care colleagues to try and resolve some of those issues. Some areas where we've had some improvement, but it's still missing the target, are length of wait for discharge. So once somebody's been declared medically optimised for discharge, the targets on Pathway 1 are 2 days, and on Pathway 3 it's 7 days or 6.5 days. But we're not meeting those. We've had significant improvement in the Pathway 1 discharges. A lot of that has been because of the extra funding that we've had. And Pathway 3 is still a challenge because of complex care needs and actually sometimes waiting for health to agree that portion of the funding as well. So, it has caused some delays there. But again, all of that is being included within this task and finish group to address the concerns. Discharge to assess. We've got step-down beds at Charles Law Court. That's in amber at the moment because we were really struggling with the referrals, but actually we've had a steep uplift in that. Often, that's a result of having additional funding. So the Adult Social Care Discharge Fund has helped us there. And we've increased to a cumulative of 13 referrals into those 4 flats over the year. And we do expect by the end of the year to have met the minimum target. We've also purchased 4 additional beds at Riverview for discharge to assess, and all 8 beds were fully occupied as at the end of December. And referrals into the community reablement team is still a challenge. So that's, we have a target of 1,200 per year. And at the moment it's significantly below that, so we need to address that through the task and finish group as well. Is it a realistic target? So at the moment we've got 547 intake as at the end of December. The positive about it is that when people do come into that service, the turnaround time, length of stay, is 3.23 weeks on average against the 6-week maximum. So it's not costing us any funding over and above what we would ordinarily have costed for. My slide won't move on. There we go. That's just a very brief overview, just a snapshot of the projects that the Integration Board has. And I'm just going to give you some highlights from a couple of them here. So we've got the multidisciplinary teams, which you've heard of in previous reports that have done very, very well. Since the implementation of those 3 multidisciplinary team clusters within the primary care networks, we've seen 220 patients that have been reviewed by a multidisciplinary team, and the results were that significant decreases in demand from those particular cohorts that came through on primary and secondary care services, so very positive. We had a self-neglect pathway, phase 1 hoarding project. The hoarding assessment referral pathway has been developed, and that's been done in conjunction with West of Berkshire Safeguarding Adults Board, and it includes a standard risk assessment tool that's now been launched, commissioned 15 understanding hoarding courses, 2 mental capacity act and self-neglect courses, and those courses will all be available throughout this year, 2023. And the hoarding and self-neglect protocol and pathway have been launched together with in line with the West of Berkshire Safeguarding Adult Board. We had, so this is about improving access to and awareness of services. So we had a funding bid that was approved for Reading Voluntary Action to procure a social prescribing platform. It enables easy access to referral through services from social prescribers, through GPs, and also enables self-referral and provides reporting for us that gives us some insight into how timely the referrals are picked up, and also will enable us to identify commission gaps. We're expecting to get some of those reports around May, June time, so hopefully we'll be able to bring back to the July Health and Wellbeing Board. Following a procurement process, RVA have commissioned a Joy platform, which is also in use across Wokingham and West Berkshire. And we were also advised at our integration board earlier this week that our mental health colleagues are also beginning to use the platform as well. So it will provide a much more cohesive approach for the residents of Reading. Just some information here about service user feedback. So we have continuous feedback from our users of community reablement team indicating 100% satisfaction rate, which is really positive. We've also had some great feedback from people using our technology-enabled care services. So over 94%, feeling that the introduction of tech has helped them to carry on living at home, has helped them to feel safe, and helped them to manage their overall well-being, which is, really great. And as you heard Amanda say earlier, we're investing in continuation of the tech projects. Adult social care funds. So we had £1.2 million allocated. And in fact, I'm just about to submit the last return today. So we've got an even improved situation on this, but this was the last return that we did on the 3rd of March. So just a summary there of activity. So over 7,000 hours of home and domiciliary care, 500 hours of reablement, 65 residential care beds having been used, 41 nursing care beds and 20 intermediate care beds funded through that fund. And as at the 26th of February, we had spent a total of 969,000 against that 1.2 million target. Fully expect to spend the entirety by the end of the year. And that's my presentation. Does anybody have any questions?
Thank you very much, Bev. Any questions from colleagues? Oh, yeah, Andy.
Yeah, thank you. Andy Jachersky, GP and Vice Chair of the board. On the community reablement, it's definitely under target. Do we know what the challenges have been behind not hitting the target, and what mitigations are maybe being put in place to try and improve or recover to target? Thanks.
We do. Thank you for that question, Andy. Some of the work that we're doing with the Task and Finish group has uncovered readmission rates back to hospital of an average of 40% on pathway 1. So we need to dig deeper into what the reasons are around that. We've also analysed the data in terms of the people that have passed away once they've been referred into reablement. And I've worked with Sunny Memmi, who's the operational director, and we feel that actually about 90% of those people that were referred into the reablement pathway actually should have been on an end-of-life pathway. So we're working with our colleagues at the ICB, the Integrated Care Board, in relation to how people go into that pathway and end of life. And we're looking at options that we can think about for this year in our planning around the Better Care Fund, and how we can really make that clear in terms of a pathway out of hospital for people where that's appropriate. And we believe if we can tackle those two things, that will make a really big difference in terms of the performance against the national target. It's a snapshot target. It's not an ideal target. That's the problem with it. Somebody could have gone in hospital and back out again in that 91-day period, and you wouldn't necessarily know that from that data. In terms of the referrals into the service, there's currently a review underway in terms of the delivery of the reablement service, looking at trying to move towards a full intake model. So taking people from the community as well as discharge from hospital. At the moment, most of the activity within our community reablement team is discharge from hospital. So I hope that answers the question.
Councillor Hoskin?
Yeah, thank you, Chair. I think one of the really important ones here, relatively new, isn't it? It's the discharge to normal place of residence. Yes. And it's really good to see that good performance, because I think that's just really important, isn't it? The idea that we can get people back to their homes as opposed to an institution is great. So I think that's fantastic, and also I think it is reassuring in the sense that we do have the services for people to support them in their homes as well. Like that started dipping away, it'd be really concerning in lots of different ways. So that's really good. My question is around the discharge from acute hospital. So obviously that's incredibly challenging across the country, and we all know the stories on the news around that and how tough things are. So I mean that seems, what's the word? A bit like the Chernobyl, isn't it? Not great, but not terrible in some ways, but we can hope to do better. What is the kind of, have we got any sense of the coming out of winter, what the sort of prognosis could be for that? Are we hoping to see sort of continued improvement, or are there challenges ahead in terms of, I'm just really asking the question in terms of what you think. You may, of course, not know, in which case that's fine.
There's always a challenging period, over the winter, and often, the Adult Social Care Discharge Fund is fantastic. It's great to get the money, but it always comes very late in the day with very, very ring-fenced specific criteria. So it would be really great, and we talked to our Better Care Fund colleagues and NHS England about this, if we could have more of a commitment longer term so that we can plan for that and get value for money, get the staff in place. When we get the money and we know what it's ring fenced for, then it's a case of going out and having to recruit agency staff, get them on board, and then work with them to support the discharges. So it is a challenge. It's been a consistent challenge. We can see ways of improving it, and that's really what we're working with our Better Care Fund colleagues on, and trying to get that commitment to longer term to give us an opportunity to really kind of be ahead of the curve, rather than trying to address it at that point of need, and understand. We've had additional capacity actually in the market as a result of the fund as well, which has helped. It's about shaping that to make sure we've got the right capacity in the market to meet the need of people coming out of hospital.
Sorry, can I say that? It just occurred to me that that's really interesting, and I think it's a bit of a continual story, isn't it? The money coming very late, and it could have been. We could be planning for all this a lot for. Well, we do plan, but obviously we've had that additional resources if it's known. What happened to that? What I thought was that terrible government plan of just block booking homes to sort of stick people in. The opposite, of course, of our plans. Did that just die death because it was such a terrible idea? Or? Sorry, Mike.
Each local authority have approached the use of the fund differently. Some people have done block booking. We have a small amount of block booking, but it's been more a case of spot purchase based on need, which seems to be more flexible, although the flip side of that is it can take a bit more time to arrange. So, and also it has an impact actually on discharge to normal place of residence, because if they want to clear the bed in hospital, but somebody can't quite go home, straight away, then actually there's more likelihood that they'll be using those beds. which means that they're not being discharged to normal place of residence. So it has an impact there. Not a massive impact, but it does have a slight impact there.
Okay, thanks.
Thank you, Bev. Melissa, you had a question?
That's all right. Thank you. My name's Melissa Wise. I'm the Director for Adult Social Care here at Reading. I just wanted to pick up on Councillor Hoskins' point, really, and build on what Bev was saying. So I think for us in Reading, when we looked at the winter pressures, it was really important that we focused on that home first approach. So as Bev said, we didn't just block book lots of beds. Actually, what we also bought was a lot of hours in the community to get people home. So we really tried to tackle it in both of those ways. And I think Bev's explained the numbers, which were really quite high, which was great to really supplement what we've already got in the community. I think going back again to that idea around let's block book lots of beds, we made a really conscious decision, in fact, in Berkshire West, that we weren't going to do that. We have, as you know, we've got very strong home first ethos in Reading, as do the others, and it just really wasn't the right solution. You do have to have a proportion of beds, of course, for some of those really complex service users. But yeah, we were really clear and pushed back quite early on that wasn't what we wanted to do, not just for the patients, but for what that does to the marketplace then in terms of the future. So I think that was a really good idea. I think the point made about what's going to happen next, and I think Eamon might well come on to it. Winter is difficult and tricky, but we're all seeing a sustained increase of people coming in for our services. So what might have been previously where you would see the obvious peaks and troughs don't necessarily feel like peaks and troughs in the same way. So I think what we need to do as a system, and we are as an integrated care partnership, is look at how we have a sustained increase of services, but be able to flex when it does have those peaks for winter. And that settlement around money, of course, is a tricky one, and that conversation, but those are happening at the moment around how we make best use of those funds over a longer period.
Thank you. Thanks.
Eamon, you've got a question?
It's a really good question. Apologies, schoolboy error. My name's Eamon, I'm Chief Nurse in Royal Berks. Thank you for inviting me here today. Just to pick up on that question, I think if you move to slide 84 in the pack, you can see a really great example of what Melissa has just said. The kind of the idea of kind of winter summer is less and less. The kind of what our clinicians say in the hospital is that winter now stops on the end of April and begins again on the 1st of May. And whereas before there would be a period of relief, we're just not seeing that now. And as you can see in slide 84, you can actually see the increase really in what we call stranded patients. It's not a great term, but it's patients who some will actually be waiting for BEVS care, some will be waiting for other areas within the system, but there's no real gap in the summer. And if anything, it's just continued all the way through. So it's an important point, and I absolutely support Melissa and Bev's position and statement around sustained funding and looking well in advance. I think would make a real impact.
Thank you, Bev. Do we have any further questions? Councillor Brock?
More of a rant, I suppose. It's, you know, we do focus on discharge. It's really important. I think Councillor Hoskins' sort of question is the kind of key one, and you can see in other places not that far away, let's name them, like Oxfordshire, where the relationship has become very antagonistic between the NHS and the council in terms of managing that process. And I think, you know, if we're all honest about what medically optimized for discharge means, it means, you know, people who are really not very well, who are leaving hospital. And that means that the sort of boundary between what we would call healthcare and social care is much more porous than it has been in the past. That's not necessarily a bad thing. I think the divide has often been pretty artificial, actually. But it also means that if we're going to succeed in that sort of environment, and we need to, because that's what's required to ensure that both the health system and the social care system can sustain itself, we do have to really embrace this sort of integration agenda. And that's difficult because we come from slightly different places, and we certainly come from different financial places, the council and the NHS. But we have to break down, I think, some of those siloed mentalities that we have had as organisations, and ensure that we do collaborate, and that we collaborate with other partners, and some of that good work that was discussed here around some of the collaborations with the voluntary sector and social prescribing in particular, and the opportunities around that. But it is going to be a tremendously difficult period of 5 years, a decade more, to really get this stuff right. But I think we should be proud of the way in which we've approached it here in Reading compared to some other places, because we have approached it in a collaborative way. And I think it's incumbent on all of us as sort of leaders in different capacities, whether it's, you know, officers or councillors, to sort of, I suppose, embrace that culture and be evangelists for it. I think we need to believe in it, well, get ourselves to a place where we can believe in it, and then do that work of encouraging others to come on board with it, and not see it as a sort of cynical, oh, this is just the way it has to be. You know, we have to really try and make some meaningful benefit out of it. That was kind of a rant, I think, Chair. There might have been a question in there if someone wants to have a pun, but I don't think there was.
Thank you. Any further questions, points? No. Okay, well, thank you very much, Bev, for your report. Thank you very much.
Thank you.
Moving on then to agenda item 7. So it's the Royal Berkshire NHS Foundation Trust operating plan, and Eamon is presenting.
Thank you, Chair. So this is quite a short paper. Just to give a little bit of background to the operating plan, it's issued by the NHS every year, normally around about November, December time, and sets out the objectives for the NHS for acute trusts in this case for the forthcoming year. So if I can take you to slide 64, you can see the 12 objectives that are set out there by the NHS for acute trusts for 23-24. Now it does reference acute trusts, but of course the success here is really down to working as a system and working across place, and working across Bob, and picking up on Councillor Brock's kind of statement there. I think we have got really good relationships, and our success here is the success of the system. But if I take these 12 particular objectives, some we're actually overperforming on right at the moment. So some of the longer wait elements, and some will be a particular challenge to us moving into next year, but actually not just a challenge to us, more of a national challenge. So the ones that jump out really are around diagnostic tests within 6 weeks. For the Royal Berks and indeed many other acute trusts, that comes down to endoscopy capacity and also histopathology capacity, and that's largely workforce related. So essentially endoscopists and histopathologists. So that's a big drive for us to look at how we can do things differently. So training up nurse endoscopists instead of doctors, for example, and also looking at outsourcing some histopathology and also recruiting nationally. And we have had some really good success recently at recruiting some histopathologists from the north of England. The other element which will be a pressure for us, but I'm pleased to say it's a resolving pressure, is cancer patients waiting over 62 days. So we have seen some significant improvement in that in the last 6 weeks. And then also the financial pressures as well are significant right across the NHS, and that's something that we'll be leaning into as well. But that's just a quick, this is a short paper, it's just a quick canter through. We're optimistic, and we are absolutely going to attempt to overachieve against these targets, but diagnostics, imaging, and budgetary challenges will be kind of our challenge and challenge of other acute trusts.
Thank you, Eamon. Do we have any questions from colleagues? Councillor Hoskin?
Between two, got confused then. Thanks for that, and I think it's a really good sort of rundown of some of the challenges you got. I think one of the ones that really worries me is the workforce element, and I just wonder if there's any. We often talk about working together and, you know, making sort of like Reading area a more attractive place for people to come in and all this kind of stuff. Is there anything perhaps we can think of doing that's a little bit different to other areas, or anything innovative to kind of address that? I just really worry that that workforce issue is going to get worse and worse and worse until some government takes this whole training by the horns and rapidly increases that. But even then, it's going to take quite a while for that to come through. So I suppose maybe I'm thinking a little bit in terms of before the Brexit element came, the guillotine came down in terms of, when we finally left. That was one of the risks in local NHS plans around workforce, and we know that citizens of the EU have kind of, we have less of them working now within the NHS. Is there any way that that's an option in terms of turning that around, or is that a lost cause?
Well, I suppose if you talk about the workforce, it's a huge challenge. It's number one for every chief nurse, every chief executive, every medical director across the NHS. Obviously, we're waiting for the people plan to see what the figures will look like and how that will shape up in terms of the long-term piece. I'm actually quite optimistic in the Royal Berks. I think we're doing some really innovative pieces around recruitment and especially retention. So we've just put in what we call a turbocharge team to really focus on retention and almost case manage each individual clinician in terms of their career pathway, because one lost nurse it can take up to £11,000 to replace a lost nurse, per nurse, and we've got 1,600 of them, and midwives. So real unrelenting focus on keeping our great people. That's number one. And the reason I'm optimistic is if we look at the national inpatients, if we look at the national staff survey, which was released last week, the Royal Berks has gone from 11th to 7th in the country for staff experience. That's really important. So we have to work really, really hard on climbing up and actually making that even better. So that's number one for me. The other piece is around working with community partners around really attracting young people into the health service, because it's getting a bit of a tough image at the moment, but it's a great career. There's over 300 different jobs within the NHS. So we're working really closely on T-level education with young people with Henley College and Reading College as well. So looking right back, and even our junior carers, 7 and 8-year-olds in local schools. So we're going in very young, right the way through, to a really robust retention plan. That's not to say it is really, really difficult at the moment with industrial action, with the living wage and all of the other stresses and strains. I don't want to create an over rosy picture, but I am overall I'm optimistic, but it takes a huge amount of effort, and we are not immune from the national challenges, as I said, around HE and training posts for certain trainee doctors and registered nurses and therapists. So for example, diagnostic radiographers, we're just not training enough in England, and that hurts us, and that affects us in terms of cancer care, as it does every other trust. The other big piece for us is we're really successful at overseas recruitment. So we recruit around about 150 internationally educated nurses, midwives, therapists and doctors every year. And I can see that having to continue for certainly the foreseeable future for the next 3 to 4 years, but welcoming these people into the community and really stressing the USP of living in Berkshire. It's a great place to live. And these young people largely feel very welcome here. So yes, it's really, really tough. It's the toughest that I've seen it, but I am optimistic, and I think that's important. And the staff survey really, really has given the trust a real boost in the last week.
Thank you, Eamon. Any other questions from colleagues? No. I was to say thank you very much for the report. We can see the operating standards, and just to sort of expand on which of the standards are going to be the most difficult to deliver, and which are the most sort of challenging.
So
around staffing.
The 10% productivity in pathology and imaging networks, that'll be a real challenge, I think, for most acute trusts. The diagnostic tests within 6 weeks, as I said, around endoscopists and histopathologists. We are under quite a bit of stress for our reducing the number of cancer patients waiting over 62 days, but we've seen a really significant improvement in that just in the last 8 weeks. And of course, then there's the emergency target as well, achieving consistency at least 76%. But as I say, we're not unique. That's pretty much, if you have any chief nurse or COO or medical director here, they'd probably say the same. But they would be the challenges. We're also doing really, really well on patients waiting a very long time. In fact, we're well below the national average, and in many of our surgical elective specialties, we're back to pre-pandemic levels, where many other trusts are nowhere near that. And we've actually been reaching out to other acute trusts to do some elective surgical work in some specialties as well. So it's a mixed picture.
Okay, thank you. Thanks, Simon. Any other questions from colleagues? No, I can't see any. Okay, thank you very much. So if we move on then to the next item, which is the performance report.
Yeah, thank you, Chair. So this, colleagues may have seen the Trust's, what we call the IPR previously. It's issued, it's a public document. It's presented at each of our public boards. But this is the first new style report that we've done. So it's very, very different to what colleagues will have seen before and what was previously been on our website. So it's broken down into three areas, really. First of all, there's our strategic priorities, so our big ticket strategic priorities that we're focusing on the next kind of 1 to 5 years, turning the dial on those. Then there's what we call the breakthrough priorities, which are more tactical, really, and they're kind of the next 0 to 12 to 18 months. And then there's what we call the watch metrics, which are regulatory and compliance metrics that we need to keep a very close eye on, and the board needs to be aware of if any of them are going off target. So the structured report is very different. It uses SBC charts to track improvement. But if I just move, I guess, to page 69, just to give you an overall summary. So this is, I believe, the January report, which reports on the period in December. That was a really December and January, both in the acute trust and right across the health system, was a period of great pressure. It was certainly the busiest winter that we've seen since we've collected records in terms of activity, both primarily through our emergency pathway. So we had various layers of infection from COVID to norovirus and to RSV, on top of a whole variety of different kind of issues within the community, meant that our emergency and urgent care pathway was under a huge amount of pressure. Just in summary, over this period, we did see a drop-off in emergency department performance. We saw a drop-off in certain cancer performance around 62 days, which we've now recovered. We are now seeing an improvement also in our emergency department performance, just really in the last 6 to 8 weeks. And I guess that's probably the headline, really, a period of extreme pressure for us, between 18 and 30% increase in access to urgent and emergency care. It did also coincide with the opening of the urgent care centre in Reading. We're obviously working really closely with colleagues around that at diverting appropriate patients to the urgent care centre. But that's really just a quick canter through. I'm happy to take any questions on the document. It's very comprehensive, but I'm happy to take any questions.
Thank you, Eamon. Any questions from colleagues? Oh, sorry, Andy.
Yeah, thanks, Eamon. Andy Jajerski, GP again. Yeah, just interested, that last comment about the UCC, how much of a difference it's made, and whether the processes for getting patients transferred from coming into the ED when actually they're more appropriately seen at the UCC, how that's come across and how the public have found that. Thank you.
Yeah, I think it's work ongoing. I'm not sure if Sarah's on the line. Sarah Webster, she's really been instrumental in working with us with the UCC. So we're currently evaluating. I think there's more opportunity. We've got 100 slots, if you like, a day. We're not always using those 100 slots. So we're working really closely with Sarah's team about how we can actually maximise that and how we can digitalise the referral systems and work much closer. But again, I'm quite optimistic. It does feel as if it's made a difference. We're analysing the data to actually quantify that, and I think there'll be even greater opportunity once we digitalise some of the systems as well, because as you know, we use different systems, which is across the NHS and social care, which doesn't always make sense. So at the moment we are giving patients, we're manually referring them. So again, we're very close to a digital solution there as well. But yeah.
Oh, thanks, Simon. Thank you. I was going to, when I was reading through all the information, ask about staffing, but I think you've covered that really.
Yes, our turbocharged team.
But I think you've covered that quite comprehensively. So, thank you. Yeah. So, no other questions then. Thanks very much, then, Eamon. And we'll move on to the next item, which is the Bob Integrated Care System update, and we have Sarah Webster who's presenting. Sorry, no, it's not. Take that back. It's Belinda. Belinda's assistant. Hello.
Hi. Okay. So, got a bit of echo. So I'm going to take. No, still got some echo. So I'm going to take the slide pack as read. The ICP strategy, having been considered by the board earlier in March, is due for imminent publication. We're going to be hearing in the next item around the joint forward plan and how integral the Health and Wellbeing Board and socialising the joint forward plan is. So we're going to be hearing a little bit more in the next item around the plans for that level of engagement. So the place-based partnership development, as colleagues will be aware, we moved to a ICB and place structure back in the 1st of July of last year. And that's about having a more of a local focus than what happens at an ICB level currently. So we've already got a history of working collaboratively. We have a joint health and wellbeing board strategy. We have strong existing partnerships. And the next step is really about how we build on this for the benefit of the population we serve. So there's work underway, as you would expect, and really that piece of work is in two parts. First is around the governance. So actually, what are the structure that we need to have in place for our place-based partnership? What are the principles of working? Who needs to be there? What's the membership? And then the next part is around the work plan. So what are the key things that we need to work on collectively, that actually it needs us to work on these things collectively to really push the dial on them and have the greatest impact. So things are moving quite quickly, hoping to get a level of consensus on this. We have a working group in place that meets on a weekly basis, which includes the DASs and directors within the NHS. So we're very actively looking at this, and so happy to take any questions.
Thank you, Belinda. Do we have any questions from colleagues? No, I was going to ask really quickly, just how will we as a board be able to review the progress against the actions that have been highlighted?
So, I'll come off the echo. So, no, it's still got some echo. So, Chair, so in terms of the actions, let me just check what you're referring to on the report. I'm assuming, let's just see. So, Chair, if you can just clarify which actions.
Yeah, well, it was just how will the whole process of the report be reviewed? Yeah, and how will how we and as a board can review the ongoing work.
Yeah, so if this is in relation to the joint forward, sorry, I can hear echo. So if this is in relation to the joint forward plan, as the guidance states, it's really important that that the plan and the kind of proposals are socialised with the Health and Wellbeing Board. And actually what you'll see within the joint forward plan, which is a 5-year plan, is that it's very complementary to, the existing strategies and priorities. So I believe the next item will actually talk through some of the proposals around that as to how, particularly thinking about the pre-election period, this Health and Wellbeing Board are consulted with on that, if we're talking about the joint forward plan, Chair.
Yes, yeah, thank you. Thanks very much for that, Belinda. No questions from colleagues? So thank you very much for that update. Thank you. Moving on now to agenda item 10. So we've got the procedural report on Bob ICB planned consultations. And we have Amanda again, who's presenting. Oh, apologies, I've got it done.
I think it's someone else presenting on
Okay,
that.
sorry, Amanda. Melissa is presenting this one. Apologies for that.
Thank you, Chair. So actually, helpfully introed by Belinda, I'm going to take the paper as read, but this is a procedural report really to reflect the Health and Wellbeing's planned approach to really engage in all of the work and the pace of the work from the Integrated Care Board and the various work programmes. So there's 4 key pieces of work outlined in the report that have got various deadlines and a request from different levels for engagement with the Health and Wellbeing Board, which we're naturally keen to do. Some are for decision and some are just for noting. So as outlined in section 3, the various elements, joint forward plan being one of them, we are planning to adopt a dual approach. Firstly, we're seeking delegated authority to myself in conjunction with the chair to respond to 2 specific consultations, the annual report and the performance assessment. And then a planned additional meeting of this board in June to really engage and influence the joint forward plan, given that the deadline for that is the 30th of June. Thank you.
Thank you, Melissa. Any questions or comments on this report? Nope, I don't see any. So in that case, welcome the report and note the recommended actions. Agree the recommended actions even. Everybody's agreed. Thank you very much. Thank you, Nikki. Agenda item 11, the COVID-19 and Reading vaccination update. And that, again, that's Amanda presenting this one.
Thank you, Chair. So I believe it was shared for information, but I'm happy to highlight some key items. Overall, we can see that the national estimated rates of infection have continued to rise throughout January and February. However, in terms of Reading, we're very similar with regards to the rates of infection when we're comparing ourselves nationally and in the Southeast region. The data is showing that the admissions within Royal Berkshire Hospital are reducing, as well as the numbers requiring mechanical ventilation remaining quite low. The number of COVID-related deaths amongst Reading locals, so people living in Reading, are quite small, and the total death rate is below the average for this time, for what's typical of this time of year. So the evidence is showing that the vaccines have been effective in reducing the impact of infections on hospitalizations and deaths. And although the vaccine uptake, COVID vaccine uptake in Reading is lower than the national uptake, we have seen the evidence of their effectiveness. In relation to the flu vaccine, amongst adults and children aged 2 and 3 years old, we can see that uptake there is lower than it was during 2021-22. However, between 2021-22 and this past year, there has been an increase in uptake of the flu vaccine, in particular for school-aged children. I think one of the things that we wanted to highlight is that it is extremely crucial that we continue to implement infection control, especially as we move from mitigation into recovery and living with COVID. So the promotion of ongoing vaccine uptake will be vital, particularly for those who are eligible and amongst those underserved communities. This will be important to ensure that we continue to protect our vulnerable members of our community and reduce demand on health and social care. So generally, numbers are low. The vaccine, the effectiveness of the vaccine is evident, but the key way forward is to continue to encourage uptake of vaccines for those that need it most. Thank you.
Thank you, Amanda. It's a really useful update. I've got a question from Andy.
Yeah, thank you, Amanda. Andy Jachersky, GP. Just about the spring booster campaign, do you know who is likely to be providing that? Is we had the advice from the GCVI and the NHS to provide spring boosters. What's the current picture about who will be providing that? Thank you.
Thank you. I'm afraid I'm not certain of who will be providing that, but that's something I can find out and share the relevant information once I do.
Thank you. Thanks very much, Amanda. I was just going to say, welcome the report, and just a quick question. Now that the program, the vaccine program, has concluded, how will we be able to update the board?
So I think we can provide updates. Oh, okay, there seems to be an echo. We can continue to provide updates through different meetings and platforms. We can provide updates in the form of reports just for information. But if you could provide a bit of clarity around your question, are you saying what routes do you want to receive updates on, or do you mind rephrasing that question? Sorry for that.
Yeah, sorry. It was really just, with now that the vaccination and all the work, the good work that's happened, since with the COVID vaccination, and now that, you're not providing, we need sort of a strategy going forward, and in terms of how you're going to report back to the board in terms of vaccination rates, so whether it's for, 6 monthly or,
I think the frequency, pretty much what you proposed of 6 monthly would probably be the most practical. But again, I'm open to taking guidance on that. It's not something that I've had a chance to reflect on, but I think a 6 monthly update, that's something that would be possible to provide.
Yeah, I think that would be useful. Thank you. I've got Councillor Hoskin, first of all.
Thank you, Chair. So I was actually I'm going to ask a question about the flu vaccine uptake for school-aged children. The figures here look good compared to England. I guess the England figures look really, really bad and really concerning in some ways. Bearing in mind that flu bearing in mind that schools and school-aged children can kind of react as almost like reactors for flu across the community. So it's less in terms of the children's health and more in terms of those that could be serious at risk. So that's good. I was saying I'm sort of positively responding to that. I still think we can do better. And there's a question at I think it was the previous, or maybe the previous but one meetings of this, and it was a really good point around how clunky the online permissions system is for and I'm a parent myself, so I did it, and it was actually quite hard work. And I can see people giving up or not not being able to fill it in properly, or just not doing it. So I wonder if that's something we can have a look at and talk to. I guess it's Berkshire Healthcare Trust, isn't it? About
Yes.
revisiting, because it just feels unnecessarily bureaucratic and clunky and not helpful. But it should just be simple and encourage people to give permission.
Thank you for that.
Thank you.
Noted. I'll take that back. Thank you.
Thanks.
Andy had a question.
Yes, thank you, Andy Jachersky again. Yeah, just on the flu, I think we normally did a sort of an annual update on the previous year's flu campaign, and then also any changes to the flu campaign for the following year, because I think pretty much all children are almost covered now for flu, where before there was a staggered campaign. COVID is now becoming routine. I think we've got spring boosters in addition to the autumn boosters. It's going to looks like a twice yearly sort of program. So I suppose maybe either a 6-monthly or an annual update, as you suggested, may well be relevant, just to see how we're keeping up to date with that. Thank you.
Great, thank you.
Thank you, Andy. Any further questions or comments from colleagues? No, I don't see anybody. Amanda, thank you very much.
Thank you, Chair.
Thanks for that. And we're moving on to agenda item 12, which is the Reading Community Vaccine Champions, the evaluation report. And again, that's yourself there, Amanda. Thank you.
Thank you, Chair. This is a very quick update just for the purposes of highlighting the findings of the evaluation. So the paper covers the evaluation of phases 1 and 2 of the Community Vaccine Champions scheme, which took place in Reading. So Reading was one of the places out of 60 schemes that were funded by the Department for Levelling Up, Housing and Communities in 2022. The project was extremely successful and we enjoyed the support of a range of local system partners and stakeholders. The evaluation report highlights the groups of members of our community that were targeted, those with lower uptake of the COVID vaccine, and those at higher risk of poorer outcomes as a result of COVID. So essentially, what this evaluation report is highlighting is the journey. It was a very interesting one. It was a challenging one, but with some really good partnership working. And I wanted to highlight the recommendations within the report, which would be of great interest. There's current work taking place at the moment to develop the champions themselves, but also to explore avenues and opportunities that we can actually make best use of the valuable asset that they are, essentially. So not solely focusing on COVID, but what other areas of health and well-being could they be supporting in? So we'll be able to provide future updates at upcoming health and well-being boards. So yeah, happy to take any questions.
Thank you, Amanda. Any questions or comments from colleagues? No. Oh, Andy.
Yes, thank you again. I mean, having spent a lot of time and effort getting the community vaccine champions trained up and in place and doing the work, I think we previously discussed about not losing that momentum and that resource. We know we've got quite significant pockets of deprivation and hard to reach populations within Reading, and it would be useful to just promote those vaccine champions into maybe health and well-being champions, or whatever title we want to give them, as they've build on the skills that they've learnt and the connections that they've made in the communities they've worked with, to try and keep that momentum up, whether it's in doing health checks or promoting cancer screening, all the health benefits, and I'm sure there's many other social prescribing benefits that they could also promote, just to try and level up those communities that most disadvantaged. So just wondered whether your thoughts were on that, building on the recommendations, really.
Yes, absolutely in agreement. And as I mentioned before, the work that's happening at present is to explore these opportunities. A few that you've mentioned actually in the pipeline, with regards to how can we work with them, in particular around health checks. They've established a level of trust that is usually quite difficult to establish, and we definitely don't want to lose that. So absolutely in agreement with the suggestions that you've made. I guess what we're trying to ascertain at the moment is we're looking at how we can find resource to make sure that, you know, whatever we do with the champions is as sustainable as possible. We're looking at different opportunities to train them up so that they have opportunities to progress in their knowledge as well. And we're also comparing with other local authority areas. Some have a health champion scheme that is accredited, others don't. So we are doing a bit of that initial groundwork to see how we can progress with the work that they've done and develop them as well.
Thank you.
Thank you. Thanks, Amanda. I completely agree with comments there about the, quite frankly, amazingly good work that the champions, the health champions have done. I was fortunate enough to go to ACRE recently, and I met some of the health champions, and there was a real sense of how proud they were actually of the work that they'd done, and a real sense of community. And I said somewhere recently that I met a family with 6 members of the same family that had all volunteered, including a daughter in a school who was encouraging school children as well to be vaccinated. So I think, to utilise that really positive good work that's gone on. So thank you very much for all, to everybody that's worked so hard on this project.
Thank you, Chair.
Thank you. Okay, so moving along. Agenda item 13, which is dates of future health and well board meetings. The next date we have, I won't go through them all, but the next date we have is the 14th of July.
Chair, that's just for you to approve those dates.
Oh, okay.
And also, if you note, there needs to be a date in June, which was now been agreed. So I'll canvass people on the date in June for that extra meeting.
Okay.
Could we not, this is a bold thing, consolidate that early July date with this proposed June date into a single meeting?
I
know it's bold, but it
well, is
might
that something
work.
we can sort of look into and see if that's a plan, isn't it, to put the
we can investigate.
Yes.
Don't look so concerned, Nikki. It'll be fine. Just because you've done a calendar doesn't mean the calendar can't change.
Well, that's we're open for discussion that we can discuss via emails and things. So possibility of merging the 2 meetings. Andy?
Yeah, just to be fair to Nikki, I think there's usually quite a big agenda list for July, and to give a fair discussion to the main item that's been proposed for the 30th or for the June meeting, which was to discuss the Bob joint forward plan. I suspect there'll be quite a lot of discussion on that, so it may be worth splitting the meeting. Sorry, Councillor Brock, that's just my opinion.
Right. I think we can discuss this. We'll carry on.
Discuss the agenda setting.
Yeah. Okay, I think that's the end of the agenda then. Yeah, and is that an hour and 15 minutes? So, yeah.
Well done.
Yeah. So thank you very much, everybody.